In this class, we're going to review indications for ileostomy in adults. So again, you might want to follow along in your hard copy module or on Blackboard and make notes. I'm going to try to tell you as we go through what things to focus on and which things to just study in general. So let's first of all talk about why would an adult have an ileostomy. Now, some of this you have already heard. We talked a little about this in some of the previous classes when we were talking about problems within the colon that required resection and reanastomosis. And we talked about the fact that if you've done an anastomosis in the colon and that anastomosis is at risk for delayed healing, that is one situation in which it is very common to do a loop ileostomy. You see your loop ileostomy here is done to protect this anastomosis, to give it all the time that it needs to heal. So you're likely to see a loop ileostomy in a patient who has had a colon resection and a reanastomosis, and the surgeon is protecting that anastomosis. You might also see a temporary loop ileostomy in a patient who has had a low anterior resection. And if you remember, a low anterior resection is done for a patient who has a rectal tumor that is in the mid-rectum or the proximal rectum. In that procedure, they take out the entire rectum all the way down to just above the anal canal. Then they bring the colon down and connect the colon to the anal canal. But again, if that anastomosis is under tension, they're going to want to give that anastomosis plenty of time to heal, and they're going to come up the line, as we always say, and do a loop ileostomy. There's a third situation. We're really not going to focus on that, and that's when there's a patient who has a continent diversion where we create a pelvic reservoir and connect it to the anal canal. And again, the temporary ileostomy is done to allow that anastomosis and that reservoir to heal. I don't want you to even think about that right now. We're going to cover that in detail in later classes. Now, just quickly going over how they do a loop ileostomy, this is what you end up with. You see the loop stoma. In this case, you see that the stoma is supported both by the sutures, where the surgeons turn the bowel back on itself and then sutured it to the dermis. And you also see the little plastic ridge or plastic bar that's supporting it. And this shows exactly how they do the loop ileostomy. So they bring up the loop. You see that here, distal, proximal. They have placed the little support device through the mesentery, but then notice they open the bowel, and they typically open it close to the skin, and then they create a huge lip, and they're trying to make it very easy for the stool to drain into the pouch, and they're trying to prevent drainage of the enzymatic fluid onto the skin. So you think about what you're looking at here. This is the distal, this is the proximal. They incise the bowel much closer to the distal end. That creates a very long spout on the proximal end. The proximal end is where the stool's going to come out. That's where you want a long spout so that the stool drains into the pouch. Surgeons try really hard to make that happen. And we need to be aware of that, because sometimes the way the stoma heals, we still have problems with undermining. We just need to be aware that the surgeon is almost always doing his or her best to keep that from happening. This is a great slide of a loop ileostomy. In this case, there is no bridge support. You see all of the sutures. You see the distal opening close to the skin. You see the proximal opening, and you can see that you have a significant spout on the proximal end of that loop. Now we're going to talk about conditions that would lead to ileostomy. So we talked about a surgical situation that might require temporary ileostomy. And that would be a patient who has a distal anastomosis, a colonic anastomosis that needs protection. Now we're going to talk about specific pathologic conditions that might result in a permanent ileostomy. And the first is familial adenomatous polyposis, sometimes called FAP. You may or may not see patients who have this. It's not that common, but it's a very difficult condition for patients and families to deal with. So let me explain to you what it is. For most patients, it's a hereditary condition. There's actually a mutation in a gene that causes polyps to begin to develop when that person hits puberty. So usually about age 12 or 13 is when you start to see polyps developing in the colon. Now, of course, initially they're asymptomatic. And so unless this individual is undergoing routine screening, he or she would not know that they had polyps in the colon. As the polyps become larger and as they move toward malignancy, they start noticing rectal bleeding. They might have some abdominal discomfort, some cramping if the polyps are large enough. There is a small group of patients where no one else in the family has it, so it clearly, in those patients, is not a hereditary condition, it's a spontaneous genetic mutation. But once that genetic mutation occurs, then they can pass that up. Now I want you to notice that almost 100% of patients with familial adenomatous polyposis will develop colon cancer if the colon and rectum are not removed, because these polyps will get bigger and bigger and they will cross over into malignancy. Later on, when we talk about oncology issues for ostomy patients, we'll talk about the fact that current science indicates that almost all colorectal cancer starts out as a polyp. So that means that polyps need to be monitored, polyps need to be removed whenever possible. I want you to see the problem here. Let me see if I can find my other slide. See where you literally have just hundreds and thousands of polyps lining the colon. There is no way you can get all those polyps out. Very different than when someone goes in for a colonoscopy and they say, oh, you had 2 polyps and we removed them and they were benign. No, here the patient is producing hundreds, sometimes thousands of polyps. There's no way to just remove the polyps. You have to remove the colon and the rectum. Okay? So that is the curative treatment. Get rid of the colon, get rid of the rectum. That's where all the polyps originate. Do an ileostomy. Today, patients also have the option to have the colon and rectum removed and to have a reservoir created out of the end of the ileum and have that reservoir attached to the anal canal. Again, I don't want you to worry about that. We'll talk about that in a later class. I want you to stay focused on when we say a patient has familial adenomatous polyposis, what does that mean? Familial tells you it's hereditary. Adenomatous tells you that that's the type of polyp. Adenomatous polyps are polyps that protrude into the lumen of the bowel. And polyposis just tells you you have multiple polyps forming in the colon. So prophylactic proctocolectomy with standard ileostomy, that is the standard of care to remove the colon and rectum, to do either a permanent ileostomy or a kind of diversion. But remember, this is a genetic condition. So if someone comes in and is diagnosed as having familial adenomatous polyposis, it's critical to do screening for all their siblings and for their children once they reach puberty. It's also important when you think about the fact that almost all of these patients are going to be in their teens, 20s, or 30s. It's critical to provide genetic counseling because a lot of these people are deciding whether or not they're going to have children and they need to know the implications. Because it's autosomal dominant, it means that with each pregnancy, there's a 50% chance that that child will develop FAP. It can be treated, but they need to know what they're dealing with. Now, Gardner syndrome is a modification a familial adenomatous polyposis. I'm going to go over this with you. We are not going to test you on Gardner syndrome. It's less common than familial adenomatous polyposis. If you have a patient, you're going to want to look it up. That's your rule of thumb for any condition that you're not familiar with. If you see a diagnosis on the chart and you don't know what it means, you go look it up so that you can talk with that patient and give them accurate information. But you see, the problem with Gardner syndrome is that the polyps are not limited to the colon. They're elsewhere in the GI tract, and they're associated with malignancies elsewhere in the body. So I'm just going to show you some of the manifestations. You can have cancer of the thyroid, that's what you see here. You can have cancer of the ampulla of Vater, that's where the pancreatic duct empties into the small bowel. Okay. And you can have malignancies elsewhere in the GI tract. There you see it in the ileum. So how do you treat Gardner syndrome? Basically the same way. Most of the polyps are in the colon, so usually they do go ahead and do a proctocolectomy and an ileostomy prophylactically to keep any of those polyps from becoming malignant. And beyond that is ongoing surveillance and treatment of any additional lesions that occur. Now we're going to spend most of our time talking about inflammatory bowel disease, because most of the patients you care for who have an ileostomy will have had that ileostomy done because of inflammatory bowel disease. I want to just go ahead and differentiate between inflammatory bowel disease, known as IBD, and irritable bowel syndrome, known as IBS. With inflammatory bowel disease, there are very distinct pathological changes in the bowel wall. They can be seen. They can be appreciated on biopsy, on x-ray. These lesions present very profound symptomatology, bleeding, edema, weight loss, all kinds of things that we're going to talk about. IBS, which sounds a lot like IBD, is a very different condition. Irritable bowel syndrome is a motility disorder. There are no obvious lesions when you look at the colon of a patient with IBS. They do have definite symptomatology, but it all comes from abnormalities in bowel motility. We'll actually talk about IBS in our module on continence, but I just wanted to clarify right now, as you go through the ostomy module, that IBD and IBS very different. IBD, definable pathology, IBS, a motility disorder. Now, as you see here, there's two distinct types of inflammatory bowel disease. There's chronic ulcerative colitis and there's Crohn's disease. Now, there's also a few patients where it's not perfectly clear whether they have ulcerative colitis or they have Crohn's disease. Most of the time, though, it's pretty obvious, and you're going to see why it's usually obvious, because we're going to go through the pathology of each of these conditions and the differences in each of these. How do these patients get diagnosed? Well, it starts with symptomatology, and we're going to talk about the symptoms in more detail, but kind of across the board, they have a lot of cramping pain, they have diarrhea, they have bleeding that leads to anemia, they may have nausea and vomiting, they frequently have weight loss, and the pathology progresses, the symptomatology progresses, so that someone who thinks, oh, I have a GI bug, but 4 weeks later they're losing weight, they're having 10, 12, 14 stools a day, they're having a lot of bloody mucus through the rectum, then it becomes obvious to them something else is going on. And then when they go to the physician, that's when they get diagnosed. Now, fortunately, most physicians are much more aware of inflammatory bowel disease today than they used to be, and they will promptly refer the patient to a GI specialist, and so most patients get diagnosed relatively quickly, whereas in the past this was not always true. What's involved in the workup, they're going to do a thorough history, they're going to do a basic physical exam focusing on abdominal exam, perirectal exam, anal rectal exam. They're definitely going to do stool studies, they're going to be looking for blood, they're going to be ruling out parasites, that kind of thing. And they're going to routinely do x-ray, and almost always they're going to do colonoscopy. And when they do colonoscopy, or an upper GI endoscopy, then they're going to do biopsies. And it's the x-rays and the biopsies that very clearly define that, yes, this patient has inflammatory bowel disease. Now, am I going to ask you details, or are we going to ask you details about the diagnostic workup? No. We just want you to know that these patients have very significant symptomatology that will be captured on history. The physical exam may or may not be contributory. The x-rays and the endoscopy, they are very, very contributory. Now let's look at epidemiology. This is very important to us because this tells us who has this condition, who are we dealing with. And it's very sad because it's almost always young adults. Peak incidence is teens, 20s, and 30s, and then there's a second peak in the 50s. But you have to know that children and even infants can have inflammatory bowel disease, as can older adults. Now, it's much more common among Caucasian and Jewish populations. The reasons for that are not clearly understood. Also more common in colder climates than it is in warmer climates. What causes it? That's what your patient wants to know. How did I get this? Why did I get this? Where did I get this? And at this point in time, we don't have clear answers. I'm going to quickly go through the theories, and you know when there's a bunch of theories, that means we don't really know the answer. So we're just going to summarize what we do know. I want you to focus on the bottom line, and I will get to the bottom line in just a minute. Okay, so you have all of these symptoms. There's a lot of inflammation. And a common question is, well, is this infectious in origin? And there have been a lot of studies done. There's some studies that indicate that Mycobacterium paratuberculosis may act as a trigger. Doesn't really seem to be the causative factor because treating it doesn't eliminate all the symptoms. But it is possible that either this organism or other organisms in the gut actually trigger the inflammatory response. We're going to talk in just a minute, well, right now, about the fact that patients with Crohn's disease and ulcerative colitis do have genetic mutations that make them higher risk. So the current thinking is that a patient's genetically predisposed, and then something turns on the inflammatory process, and that it could very well be a GI bug that causes a change in the normal flora that triggers the inflammatory process. Okay. So look at genetic factors. Now, once they've done the gene mapping, they were able to identify some specific abnormalities among patients with Crohn's and patients with ulcerative colitis. Some of those abnormalities overlap, but some of them are distinct. Now, obviously, this holds a lot of promise for future treatment. If they can clearly identify the genetic mutations, then the question is, okay, can we do any kind of gene therapy to correct it? Obviously, we're not there, but research is ongoing. Now, we know that this is an autoimmune process. All of the features of the disease, the profound inflammation, the formation of granulomas, which are inflammatory lesions, the fact that these conditions respond well to steroid therapy and to other anti-inflammatory agents, all clearly indicates that it's autoimmune. That's what it is. But what we don't know is really what causes it. And again, the current thinking is that some alteration is in genetic makeup, some alteration in the chromosomes makes that patient more susceptible, that then a GI bug or, something activates the inflammatory process. So let's say you're genetically predisposed, but you've been doing okay, but now you get a GI bug and everything changes in your GI tract, and you have an acute inflammatory response, and you have abnormalities in the bacterial makeup of the colon. That can activate the process because it's going to turn on that inflammatory response. And then for a patient who's genetically predisposed, it can be very hard to turn it off again. So again, you keep coming back to genetic predisposition that makes that patient very high risk for this abnormal response to the bacteria in the bowel. We're not totally clear what turns it on, but in a number of patients it seems to be activated by a gastroenteritis that would trigger inflammation in the gut, that would alter the flora and the lumen of the bowel, and that seems to activate the process. Now, one thing that's very important that I want you to know, what about psychosomatic factors? When I was in nursing school 1,000 years ago, we were taught that these were psychosomatic conditions. And I have heard so many nurses say, oh, he's got a classic Crohn's personality, or you can tell she has ulcerative colitis. I want you to know that research has shown no link between any psychological characteristics and these diseases. It is true that if you have Crohn's or you have ulcerative colitis, that high stress levels can activate a flare-up or can make a flare-up worse. There is absolutely no evidence that any psychosomatic processes cause this disease. And you can't treat people psychologically. This is a physical condition. And it's one of the things you want to tell your patients, because they're going to hear this. And you want them to know, no, this is not in your head, and this is not your fault. This is in your gut. And we don't know exactly what causes it, but it has nothing to do with your brain. It has something to do with your genetic makeup, the bacteria in your gut, that work together to create this chronic inflammation. Also, if you hear staff saying that, you want to interrupt that. You want to change that perception. You want to say, you know what, there is no evidence to support that. And I sometimes will say to staff, well, you know what, I wonder what I would be like if I was having 14 bowel movements a day and I never knew if I was going to make it to the bathroom or not. And I never knew if I was going to feel well enough to go out with my friends or well enough to go to my child's play at school. I think most of us would act differently. Now, what about dietary intolerance? Definitely not the causative factor, although a lot of patients do have certain foods that they say they can't tolerate during flare-ups. About 1 in 3 of patients with IBD are lactose intolerant. But might contribute, does not cause. No evidence that anything in the diet causes IBD. Now, there is some support, and we'll come back to this because there's actually some good research looking at the role of probiotics and prebiotics. And remember, probiotics are the good bacteria like lactobacilli, like bifidobacterium, like Saccharomyces. Prebiotics are the dietary fiber. And the interaction between the dietary fiber and the good bacteria produces a lot of protective compounds that help to keep the mucosa of the gut healthy, help to prevent invasion by bacteria or irritants. And so we do have some good research that says keeping patients on probiotics, making sure they're getting enough soluble fiber, can help reduce the number of flare-ups or the severity of flare-ups, and can keep people healthier. So should we be talking to our patients about probiotics and the importance of soluble fiber in their diet? Absolutely. But is it a cure? No. Now there's some other things, we're not going to ask you about any of those things. Just tells you how much we don't know. Smoking nicotine, very interesting because it seems to protect against ulcerative colitis, but it makes Crohn's worse. So I had a patient who was a smoker. She was diagnosed with Crohn's disease, that was really hard for her to quit smoking, but she's like, I've got to quit smoking because it's making me sicker, and I'm sick enough already. So why would it protect against ulcerative colitis? We don't know. Why would it do one for ulcerative colitis, something else for Crohn's? Again, we don't know. There's some link to higher dose, higher estrogen levels in oral contraceptives. So once they switch to the very low dose oral contraceptives, women with Crohn's disease noticed an improvement. Again, what's the link? We don't know. Coagulation disorders seem to help, which is interesting. So then they think, well, is there some link between hypercoagulability and IBD? I'm not going to ask you any of that. What I want you to know, what you would tell your patient, is the bottom line. And the current bottom line is that hereditary factors make some individuals high risk, much more susceptible. And that then something triggers the inflammatory process. And that once that inflammatory process gets triggered, then it kicks into that autoimmune disorder where it's very, very hard to control the inflammation, very hard to turn off the process. Most likely the triggering factor is abnormalities in the bacteria within the lumen of the bowel. Now, we're going to spend a little bit of time talking about the difference between ulcerative colitis and Crohn's disease. I am not going to have you focus on details. I want you to pay attention to the fact that in your hard copy module, we have put in bold the things we really want you to know. Let's start with ulcerative colitis. If you have to have inflammatory bowel disease, you'd much rather have ulcerative colitis because, number one, it is confined to the mucosal and submucosal layers of the bowel. It typically does not extend to involve the muscle layer or the serosal layer. The one exception is an acute complication of ulcerative colitis known as toxic megacolon, which we talked about in a previous class. With toxic megacolon, because you have a very rapidly progressing inflammatory response, it does involve the muscle and the nerve plexuses, shuts down motility, you get collapse of the distal bowel, rapid distension and dilatation of the proximal bowel, high risk for perforation. But in general, when you think about ulcerative colitis, if I was asking you about characteristics of ulcerative colitis, you would think confined to the mucosal and submucosal layers. The other thing is that ulcerative colitis always starts in the rectum, always. And it proceeds proximally with no skip areas. So first you get rectal involvement, then you get involvement of the sigmoid, then involvement of the descending colon. Ulcerative colitis never involves the small bowel. Go back to the name, ulcerative colitis. Involves only the colon, acute inflammation, ulcer formation within the mucosal and submucosal layers. So here's your healthy colon, and now you see all of these little ulcers forming. Think of the little ulcers you sometimes get inside your mouth, those little aphthous ulcers, and think how painful they can be and how they can erode into those little yellow-white ulcers where everything hurts. And then think, what if you had large ulcers like that that were throughout your rectum or throughout your sigmoid, and you can understand how sick these patients are. Okay, I put this slide in. I think it's incredibly helpful just to see that there's a clear line of demarcation between the diseased bowel and the healthy bowel. This is a colon that has been removed, obviously, and has been opened. That's why it looks pale yellow instead of looking red. But what I want you to notice, it started at the rectum, it comes up, 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 and at this point it stops right here. So I want you to get that concept. Ulcerative colitis starts in the rectum, proceeds proximally, no skip areas, involves primarily the mucosal and the submucosal layers. Because you have all these ulcerations, they have bloody mucousy stools, okay? Because the ulcers in the mucosal and submucosal layer expose blood vessels, and so they're bleeding. They're producing a lot of mucus. That blood and mucus and the acute inflammation causes patients to feel like they have to go to the bathroom all the time. It's a condition known as tenesmus, where you have frequent feelings of intense urgency. So inflammation, blood, mucus, frequent small stools. Now sometimes when a patient has an acute flare-up, they also have just massive bleeding. Depends on how severe are the ulcers, how many do they have, how severe is the inflammation, and how much of the colon's involved. So some patients end up in the hospital because their bleeding is so severe that they require blood transfusions. Sometimes the bleeding is so severe that they require surgery. Okay. But what I want you to think of is mucosal, submucosal, limited to the colon and rectum, starts distally, proceeds proximally, no skip areas. Major symptoms are going to be cramping pain, diarrhea, bloody mucousy stools. Now they talk about pseudopolyps. Pseudopolyps occur because you have intense inflammation and swelling of the mucosa right next to areas of ulcer formation, so it looks like little polyps because you have this marked change in height of the mucosa. I'm not going to ask you that. They'll also talk in the textbooks about the fact that the chronic inflammation causes shortening of the colon and loss of those normal haustrations. Remember, haustrations are the little compartments, and you can sometimes see that on x-ray. Again, I want you to focus on big picture, involves colon and rectum, starts distally, proceeds proximally, involves primarily the mucosal and submucosal layers, and the most common symptoms are abdominal pain and cramping, frequent bloody stools, usually relatively low volume bloody stools. Now, a lot of patients have weight loss. And you think, I used to wonder, why do they have weight loss? Because this is confined to the colon, and all nutrient absorption takes place in the ileum. But the reason they have weight loss is because every time they eat, that stimulates peristalsis. Then that increases frequency of the bloody mucousy stools and increases cramping. So if every time you ate, you had cramping pain, maybe mild nausea, and you had multiple bloody stools, pretty soon you wouldn't want much to eat. So it's pretty common for these patients to have weight loss just because they're not eating as much. So rectal bleeding, diarrhea, crampy pain, weight loss is common, anemia from the bleeding. Complications we've talked about. Occasionally, it's a small group of patients that develop that toxic megacolon, but you want to be aware of that. That can cause perforation that almost always leads to surgery. We've talked about the fact that bleeding can be severe. Intractability just means we can't get them off the steroids. We can't get the disease process under control. And then with long-term ulcerative colitis, there's increased risk of cancer. So patients who have had ulcerative colitis for more than 10 years, especially if it involves more than half of the colon, are higher risk for cancer. They have to be screened carefully with colonoscopy and biopsy. It's very difficult because you think about the things we tell patients to watch for in terms of signs of colorectal cancer, change of bowel habits, blood in their stool, those kinds of things. Well, these patients deal with that all the time. So we do have to be aware, we want our patients to be aware that patients with longer standing disease are higher risk for cancer and that surveillance is critical. Even if they're not so very ill, the longer they've had it, the more of the colon that's involved, the higher their risk for malignancy. And we just need to be sure our patients understand that and understand the importance of routine surveillance. How do we manage ulcerative colitis? We always start out with medical management for both ulcerative colitis and inflammatory bowel disease. And the reality is, for many patients with ulcerative colitis, we're able to get the symptoms under control, and then we're able to taper the medications way down. And many patients never ever require surgery. So surgery is done for complications. And statistically, about 30 to 40% of patients will end up having surgery, but certainly not all patients. So you see that there's a number of patients who can be managed medically and never progress to surgery. But, important to realize this, it will be on your test. If we do have to do surgery for a patient with ulcerative colitis, if we remove the colon and we remove the rectum, they are cured because the small bowel is not involved. Anal canal is not involved. So removing the colon, removing the rectum eliminates the disease process and cures that patient. Now, Crohn's disease is different. Crohn's disease is the more difficult of the two. I already said if you had to have inflammatory bowel disease, you would rather have ulcerative colitis than Crohn's disease. And I'm going to go through with you why that is. But again, I want to just start out by saying, just like ulcerative colitis, Crohn's disease, there's marked variation in each patient's experience with Crohn's disease. Some patients do extremely well for many, many, many years. Probably a lot of you have friends or family members. Some of you may have Crohn's disease. I have many friends who have Crohn's disease. They're leading totally normal lives. So even though inflammatory bowel disease is a really tough diagnosis and a really tough condition, I want you to know that the vast majority of patients do well the vast majority of the time. So initial diagnosis, miserable because they're very, very sick until they get diagnosed and put on treatment. If they're having an acute flare-up, it's miserable. But in between those acute flare-ups, most patients have long periods when they do well and feel well, either on no medication or low-dose medication. And don't forget probiotics. Okay, so let's talk about Crohn's disease. What's so different about Crohn's disease? Well, first of all, you see it's in bold on your handout. Crohn's disease produces transmural inflammation, which means all layers of the bowel wall are involved. So it's not just the mucosa and the submucosa. The mucosa, the submucosa, the muscle layer, the serosa. The serosa is continuous with the mesentery. So these patients end up with a low-grade peritonitis that produces fairly significant abdominal pain. We need to be very aware of that. Pain management is an important element of care for these patients. The other thing is that it can involve any area of the GI tract, all the way from the mouth to the anus. So I've seen Crohn's lesions in the mouth. Crohn's lesions can occur in the anal canal. It can occur anywhere in the GI tract. So you cannot cure a patient with Crohn's disease by taking out the colon, taking out the rectum. You might give them long-term remission, but you can't tell them they're cured because it could come back anywhere. So Crohn's disease is not limited to the colon and rectum, can involve any areas of the GI tract. Also, Crohn's disease, unlike ulcerative colitis, can skip around. And so you might have lesions in the sigmoid colon, and you might also have lesions in the ileum at the same time. So a more difficult disease to control than ulcerative colitis because you can't just cut it out. Even if it's bad, you can't just cut it all out because it can come back somewhere else. Now, one thing that they talk about a lot is that you can get these this cobblestone appearance of the bowel because of these very deep linear ulcers and then vertical ulcers. So it literally creates cobblestone appearance because of these crisscross ulcers, and you can see that there. You can see the cobblestone appearance. I'm not going to ask you that. I just want you to know that they can have very severe inflammation. What do you think somebody would feel like if that's what their colon looked like? They're going to be miserable. Okay. So those are the things I want you to remember. What about symptoms? Abdominal pain is significant. We talked about that. We talked about why that is. Now, we talked about the fact that patients with ulcerative colitis frequently have diarrhea, but it's usually small volume stools with a lot of blood and mucus. And what they feel is that fecal urgency and fecal frequency because of the intense inflammation of the rectum itself. So small volumes of blood and mucus in the rectum produce intense urgency and they're running to the bathroom. Patients with Crohn's also have diarrhea, but for the Crohn's patient, many times the diarrhea is high volume. Because remember, Crohn's disease can involve the small bowel and can interfere with nutrient absorption, which then causes more fluid to pass into the colon, which translates into diarrhea. The other thing that can happen is because of the inflammation that impacts absorption of nutrients, you can get bile salts dumped into the colon, which causes high volume diarrhea. You can get loops of bowel sticking to each other because the entire bowel wall is inflamed and sticky, so I can have one loop of bowel sticking to another loop of bowel. I can develop a fistula between those two loops of bowel so that stool just runs through the fistula tract. You can have this whole section of bowel that gets bypassed. So a lot of things contribute to the fact that many Crohn's patients have high volume diarrhea, translates in turn into malnutrition, profound weight loss, sometimes fluid and electrolyte abnormalities. What do I want you to remember? I want you to remember that it's common for Crohn's disease patients to have high volume diarrhea. Also very common for them to complain of having no appetite, anorexia. Some of them have nausea and vomiting on a fairly frequent basis. It depends on which sections of the bowel are involved. I remember one of my patients who had involvement of the duodenum and the duodenum and jejunum, and she said the first thing she did every morning was throw up. What a terrible way to start the day. So just be aware that because Crohn's can involve any area of the GI tract, you can get any type of GI symptoms. So abdominal pain, pretty much constant. Diarrhea, very common. Nausea, vomiting, anorexia, definitely possible. And we talked about weight loss and malnutrition. The other thing I wanted to talk about related to Crohn's is the fact that some patients with Crohn's develop perirectal disease. I mentioned this a little bit in a previous class. This is unique to Crohn's, does not occur in patients with ulcerative colitis. And what tends to happen is the intense inflammation in the rectum creates little fissures and fistulas between the rectum and the anal canal and the perineum. Now, we talked about the fact that these are very narrow tracts, so typically you don't get much stool passing through them, but they're loaded with bacteria, which causes a chronic inflammatory response, which produces foul-smelling exudate, causes intense perineal tenderness. It's hard for them to sit. They usually have major problems with sexual activity because of the drainage and the odor and the tenderness. So lots of issues. So perirectal disease is almost always associated with Crohn's disease. Sometimes you'll get perirectal disease in a patient who has not yet been diagnosed with Crohn's, and then some months to years later they are diagnosed with Crohn's. How do they deal with that? They usually have to go in there and they have to do an incision and drainage to try to get the wounds to heal from the inside out. Many times they have to do a temporary diversion, either a colostomy or an ileostomy, to stop stool passing through that area, to reduce bacterial loads, to give a chance for those lesions to heal. The other thing that you see with Crohn's disease that you do not see with ulcerative colitis is fistula formation. Why? Because it's transmural. So the outer layer of the bowel, the serosal layer, becomes very sticky. Think about the way the loops of bowel are all crammed into the abdominal cavity right next to each other. So if this loop's very sticky and this loop's very sticky, it's very easy for these loops to stick together, and then the inflammatory process can create a fistulous tract between the two. Similarly, loops of bowel can stick to the abdominal wall, and you can end up with a fistulous tract between the bowel and the abdominal wall. So most patients with Crohn's do not have perirectal disease. Most patients with Crohn's do not have fistulas. But if you have a patient with severe perirectal disease or a patient with fistulas, that means that it is highly likely that that patient has Crohn's disease. Go back to the underlying pathology. Now, what are the potential complications? Well, probably the most common one is intractability. We can't get you off steroids. Every time we try to taper you off steroids, your symptoms get much worse. Intractability is one of the complications that will prompt surgery. Occasionally obstruction, fistulas we've talked about, all of the little abscesses that can form. If you have a leak from the bowel, you can get little abscesses forming. Sometimes that's how people get diagnosed, because they are having abdominal pain, then they have a lot of tenderness, and when they do a CT or an MRI, it's like, oh look, there's an abscess right here. Well, when they go in to drain the abscess, what do they find? They find a very inflamed loop of bowel. They find a little hole in that bowel, leaking stool and bacteria, and that's what's caused the abscess. How do we treat Crohn's disease? Our mainstay in treatment of Crohn's disease is medical management. We use a variety of anti-inflammatory drugs. We're going to talk about those drugs, but only in very general terms, to try to get the inflammatory process under control. Then we try to reduce the dose or cross them over from a very potent anti-inflammatory like a steroid to an anti-inflammatory that is better tolerated long term. Many times we use anti-inflammatory agents that are specific to inflammatory substances that are commonly produced in the Crohn's disease patient, so we'll come back to that. So medical management, our mainstay. We do surgical intervention only for complications that we can't manage otherwise. So yes, if you have an abscess, we have to take you to surgery. If you have severe perirectal disease, yes, we have to go in there. We might have to do a diversion. We've got to open up all those little tracts. If we can't get you off your meds and you have one section of bowel that's just acutely inflamed, absolutely, we're going to take you to surgery and we're going to take out that section of bowel so that your quality of life improves and we can start to get you off of some of these potent medications. But here's the thing we always have to think about. Remember that a lot of these patients are young. Remember that Crohn's can come back in any area of the GI tract. We've got to think long term. So if every time you have a flare-up, I take out a section of bowel, I'm rapidly pushing you toward short bowel syndrome, toward a state where you'll be unable to meet your own nutritional needs with oral intake. You'll become dependent on TPN, and we know what that does to the liver. So whenever they're looking at a Crohn's disease patient, they're going to manage them as long as possible with medications. They're going to do surgery only if forced to do so by a complication. When they do surgery, they're going to minimize the amount of bowel resected. Okay. There is one exception. It is in your module. I want you to be aware of this because it's actually some of the patients you're most likely to see. And that is, you'll have some patients who present with Crohn's colitis, no small bowel involvement. If you remove the colon and the rectum in that patient and do like a permanent ileostomy, many of those patients have long-term remission. I'm talking sometimes 10, 20, 30 years remission. So Crohn's colitis does frequently respond well to surgery, but when you have Crohn's involving the small bowel, skipping around, you want to minimize bowel resections for the reasons we've already talked about. Okay. Now, I don't want you to get lost in this next section, but I want you to know that even though we refer to IBD as inflammatory bowel disease, it's much more than that. It is a systemic autoimmune condition. And it can definitely involve organ systems other than the gut. The gut's the primary organ system. That's what we're always focused on. But it can involve other organ systems as well. So in order, probably the complication we're most likely to see are skin disorders, pyoderma gangrenosum being number one. We will come back to pyoderma gangrenosum when we talk about peristomal complications. We'll talk about that in a lot of detail. You can have other things. You can have erythema nodosum. These are these painful raised red nodules on the lower extremities. But we're going to focus on pyoderma because that's what we see the most. They can have joint pain. They can have a lot of inflammation involving the joints. A lot of times they'll complain of arthralgia, just joint pain. You'll see that ankylosing spondylitis is 20 times more common in the patients with IBD. That causes low back pain and stiffness. Okay? Small percentage have acute arthritis. You can have involvement of the eyes. What's most common is a conjunctivitis. They can have episcleritis, uveitis. So bottom line, if their eyes are red and inflamed, they need to be seen by an ophthalmologist. They're going to require steroid drops to get that inflammation under control. The most serious of these four organ systems is liver involvement. So we always talk about SLEJ, okay? Skin, liver, eyes, and joints. Those are the four organ systems most likely to be involved. The most serious with liver disease is cancer involving the bile ducts, hepatitis, or sclerosing cholangitis, which is progressive destruction of the bile ducts. Now, fortunately, these are very rare, but you just need to be aware that they can occur and that it clearly indicates that there's more to inflammatory bowel disease than what's going on in the gut. I actually have a friend who has Crohn's involving her lungs. So even though we talk about skin, liver, eyes, and joints, I want you to just think of IBD as a systemic condition. Okay, let's talk about medical management. Now, when we talk about medical management, we're going to talk broad terms. I am not going to ask you specifics about drugs. I want you to get big picture. I want you to be able to talk to your patients. I want you to be able to understand why they're being treated the way they're being treated. I want you to always look up anything that you don't understand. So go to objectives. First, goal number one, get the inflammation under control, induce remission. Then we want to taper their medications down to either low dose, or some patients can be tapered off for periods of time. We want to minimize medications, maximize quality of life, minimize symptoms, okay? Minimize impact, maximize quality of life. Now, if we knew exactly what caused inflammatory bowel disease, we'd just go to the source and we'd treat the source. But since we don't really have a handle on that, basically what we do is we treat the inflammation. And that, of course, typically begins with steroids, which have their own set of side effects. So we're trying to treat long enough to get the inflammation under control, and then we're trying to taper down or cross over. So we're gonna talk more about that. We've talked about the fact there is no cure for Crohn's, but if you have a patient with refractory ulcerative colitis, you can't get it under control with medications, you can cure that patient by removing the colon and the rectum. We also talked about the fact that the disease trajectory is variable. This is hard for us and hard for patients because you think how you would feel if you were diagnosed with something like inflammatory bowel disease. You would have all kinds of questions like, well, how do you treat this? And how much medication am I going to have to take? And do I have to take it all the time? And well, how long is it going to take to get it under control? And once you get it under control, you know, what can I do to be sure it doesn't come back? And what can I expect long term? What kind of impact is this going to have on my quality of life? Is it going to shorten my life? Am I likely to die from this? And you know what? The answer to most of those questions is we're not sure. Now, we do know that for most patients, it does not shorten lifespan. That most patients do very well. Can we promise the patient that? No. We can say, you know, I wish I could give you concrete answers. I can't give you concrete answers. I can tell you these things. I can tell you that the majority of patients who have inflammatory bowel disease live normal lives. They have families, they go on vacation, they work, they do all the things that you and I do. Some patients go years and years and years in between flare-ups. Some patients have flare-ups more often. Some patients are rarely ill, and other patients end up in the hospital periodically. There's a lot of variation. What we know is most patients do pretty well. We also know that maintaining adherence to the treatment plan helps, that people who follow the treatment plan are seen regularly by their physician or their nurse practitioner in general do better than people who are not seen regularly. But there's a lot that we don't totally understand. So I want you to know I can't give you hard and fast answers. I can't promise you anything, but I do want to give you some basically reassuring information, and that is most people do well, most people live normal lives. You should also know that research is ongoing, that in 2013 we have much better medications than we did 10, 20 years ago, and in 10 years from now we're going to have even better medications. So I want you to be optimistic. I think you have reason to be optimistic. But I also want you to pay attention, and if you're starting to feel bad, if you think you're having a flare-up, don't ignore it. Get in here so we can get it under control. Okay, now look at the general strategies. Not surprisingly, eat a healthy diet. Consider staying on probiotics and make sure you're getting soluble fiber so those two can work together to keep your gut healthy. You know, get on some kind of regular exercise program, something as simple as walking or yoga, Pilates. That helps with stress, and it helps keeps your whole body healthy. One thing I did want to mention, specific to your young patients, they have a lot of questions about fertility and pregnancy. Basically, fertility is unaffected except for the fact that men who are taking sulfasalazine or azolfidine do have lower sperm counts while they're taking that drug, but their sperm counts go back to normal once they come off the drug. Women who are looking to get pregnant, in the past we thought, well, it was really important to get them off their medications, but no, the research shows that what matters is keeping that woman healthy. And so an acute flare-up is much more damaging than the medications, that she should stay on medications while she's trying to get pregnant and during pregnancy. Okay, let's talk about medications, but we're going to talk about medications in broad terms. Remember, I don't want you to get lost in these. I want you to use this as a reference because this is not what we're going to test you on. Big category, anti-inflammatories. You already know a lot of these things. Now, one category that you might not be so familiar with is the aminosalicylates. Now, you certainly know that aspirin has anti-inflammatory effects. Well, aminosalicylates, aspirin. Frequently used for patients with ulcerative colitis that's mild to moderately severe. Also, Crohn's colitis that's mild to moderately severe. Now, they can give the aminosalicylates both orally, and that's what I've seen a lot, patients on azolfidine. I'm going to come back to azolfidine in just a minute. But they can also give topical forms. They can give it as enemas or as suppositories. And, you know, if the patient has proctitis, okay, so the patient has ulcerative colitis that's affecting the rectum. They would not treat that systemically, they would treat it topically. They'd go in through the rectum. If you had a patient who had Crohn's colitis involving the rectosigmoid, they would treat topically, okay? The advantage of treating topically, you get the medication right where it needs to go and you don't get all the side effects. Now let's look at azolfidine. I'll briefly explain this to you. The active agent is the aspirin, but aspirin is going to get broken down long before it gets to the colon unless you protect it. So what they do is they bind it to a sulfa with an azo bond. That carries it through the stomach, through the small bowel, into the colon. The bacteria in the colon break the azo bond and release the aspirin. And so then you get the anti-inflammatory effect exactly where you want it. Interestingly, the beneficial effects of azolfidine are the salicylate. The adverse effects track back to the sulfa, which is just the carrier. So, you know, azolfidine works well for many people and it's inexpensive, but for people who are having side effects, they're developing rash or whatever, then there are some other forms, and one of the ones is valsalazine. So you might see patients who are on a more expensive form of a salicylate. Those are usually the patients who reacted to azolfidine. But I want you to remember, stay focused, big picture, aminosalicylates, think aspirin, think oral or topical. How are you going to give it? Where does it need to go? If it just needs to go to the rectum or the rectum sigmoid, you're going to give it topically. If you need to treat the entire colon, you're going to give it systemically. Doesn't have as much effect on small bowel because it becomes active in the colon. Here's the #1 drug for inflammatory bowel disease, steroids, because it's such a powerful anti-inflammatory. So that's usually the first thing they use for severe IBD flare-up is they'll use steroids to get the inflammation under control. You can use it for either ulcerative colitis or Crohn's disease. You know the issues. Great for short term, bad for long term because of all of the side effects. So the goal is give the steroids, get the inflammation under control, wean them off the steroids, cross them over to one of the newer forms of steroids, but do not keep them on something like prednisone long term. Now, the newer corticosteroids, the advantage is that there's very rapid absorption by the mucosa, so you get a rapid anti-inflammatory response, a rapid therapeutic response. And then the drug is rapidly inactivated by the liver. So they call that first pass effect. You don't have to know that. The bottom line is you get major effects at the level of the mucosa, but you get minimum systemic side effects. So a lot of times we can do something like a standard steroid to get them under control and then cross them over to the newer steroids. But in the future, you're going to see more and more attention on the monoclonal antibodies, some with immunomodulators, but primarily monoclonal antibodies. This is tied directly to the research that has been done. What they found first is that one of the major inflammatory mediators in especially Crohn's disease is TNF-alpha, tumor necrosis factor alpha. Based on that, they developed monoclonal antibodies that reduce levels of TNF-alpha. And the first one to come on the market was infliximab or Remicade. A lot of you are familiar with it. When they first came out with it, we would give it as like one treatment. But now we realize that we can use repetitive treatments of Remicade to keep the disease process under control. And there are many patients living much better lives because of Remicade and all of these other drugs. So we've got Remicade, we've got Humira, we've got Pegol, and then the newest one, Tisabri, actually works on a different inflammatory mediator, not TNF-alpha. But you see the link. As we learn more and more about the specific inflammatory mediators, they're going to use that to develop specific drugs. Eventually, we're going to be to the point where we can figure out for any patient what their inflammatory mediators are, and then we'll know which drugs are going to work best on that patient. We'll be out of this trial and error approach. So right now, I just want you to think big picture. Anti-inflammatories, sometimes you can use the salicylates. Most of the time we start with steroids, cross over to the newer steroids, and then for long-term management we start thinking about either your immunomodulators or now very commonly your monoclonal antibodies. Now we've already talked about probiotics, and there's all of your information about probiotics, the research that's been done. Again, do you have to know the specifics? No. Know that probiotics can be helpful because they give you good bacteria, they deliver good bacteria to the gut. The good bacteria interact with soluble fiber to produce protective compounds that keep the mucosa healthy. Avoid medications that slow motility because sometimes that can push the patient into toxic megacolon. What about nutritional therapy? Well, primarily we look at keeping the patient on a well-balanced diet, but I'm going to come back to probiotics and soluble fiber. One of the compounds that are produced by the interaction between the good bacteria and soluble fiber are short-chain fatty acids. Short-chain fatty acids keep the cells in the mucosal layer healthy, so help to keep the bowel wall healthy. Glutamine can also be very helpful. Now, most of the time when patients are on a good diet, a normal diet, they're going to produce enough glutamine. Some patients might benefit from glutamine supplements. Same thing with fish oil that contains the polyunsaturated fatty acids. That can be beneficial. Strongest evidence, eat a healthy diet. Pay attention to anything that acts as a trigger for you. Make sure you're getting in enough soluble fiber. Soluble fiber is like your oatmeal and all of your fiber supplements and bananas and rice and pectin, so applesauce, that kind of thing. So there's a lot of soluble fiber, and we have lots of soluble fiber supplements. So soluble fiber is fiber that attracts water but turns into a gelatinous mass, okay, as opposed to insoluble fiber, which is like the stringy cellulose in celery. So we want them on soluble fiber probiotics. A lot of research going on into probiotics, and we might find that there are very specific agents that we need to recommend. There are some probiotics that are available only in Germany. Maybe that will change. Right now, you make broad recommendations because that's what we know. But you also stay tuned because we're learning more every day, and our recommendations to our patients will change. Okay, let's just summarize again. Surgical management. Ulcerative colitis, confined to the colon and rectum. Proctocolectomy is curative, but most patients, like 70%, can get through their entire lives without surgery. So you don't rush to surgery just because someone has ulcerative colitis. You take them to surgery if they have a disabling complication. What are the complications? Toxic megacolon, the bowel's about to perforate. Hemorrhage, you can't get the bleeding under control. Intractability, you can't get them off their medications. Or on colonoscopy and biopsy, you're picking up premalignant changes. Don't worry about the options. We'll come back to that as we talk about different procedures in a later class. Right now, I just want you to think, how would you manage this disease process? What about Crohn's disease? Again, you're trying to maintain enough bowel to keep this patient off TPN. So if they have Crohn's colitis, you're very likely to do a proctocolectomy and an ileostomy, because if the inflammation is limited to the colon and the rectum, studies indicate that proctocolectomy can provide very long-term remission. But if you have Crohn's involving the small bowel, you try to limit the amount resected. You try not to go in there unless you absolutely have to. The number one indication is intractability. They have no quality of life. You can't get them off their meds. You have to take them to surgery, take out that very inflamed section of bowel so this person gets to live their lives. Okay? Certainly if they become obstructed, and patients with Crohn's disease can become obstructed if they have recurrent inflammation in the same area of the bowel, because you can get scar formation is transmural. Fistulas, of course, might require surgical repair, severe perirectal disease. I want you to think, why would you take somebody with inflammatory bowel disease to surgery? Because you can't manage them medically. You should be aware that with ulcerative colitis, it's much more likely to be intractability or hemorrhage or cancer, whereas with Crohn's disease, it's much more likely to be intractability or fistulas or perirectal disease. Can we tell that patient with Crohn's disease, you know, we're going to have to take you to surgery, but it will cure you? No, it's not curative. We can tell them you're going to feel so much better. This is going to get out that severely inflamed section. Your quality of life is going to improve dramatically. This will provide you with a remission, and we hope it's going to be long-term. Okay? Now, the other things we have to think about, think how hard it is to live with a chronic disease. Think how hard it would be if you had to look at the calendar, you were trying to make plans, and you're like, well, I'd like to do that, I hope I'm not sick. I'd like to do that, I hope this flare-up settles down. I hope I don't end up in the hospital. I hope I'm not like my friend who has to have surgery. I hope I'm not like that guy I've been talking to at Crohn's and Colitis Foundation who had to have his entire colon removed and had to have an ostomy. It's that uncertainty that makes it hard. Every time you have any kind of GI symptom, you're like, oh my gosh, am I getting worse? Am I having a flare-up? So very frustrating, very hard. Also hard because if you're in your teens or 20s or 30s, you're not supposed to be dealing with chronic illness. That's not what anybody else is talking about. And it makes you different. And nobody wants to be different. And nobody wants to hear you talk about your problems with diarrhea or rushing to the bathroom or being afraid you're not going to make it. It can be very lonely. So that takes us to the importance of hooking patients up with support groups. Crohn's and Colitis Foundation of America is phenomenal. They fund research. They also have a very strong educational and support network. You want to get your patients connected to Crohn's and Colitis Foundation of America through their website, through their local chapter. Then they get to talk to other people who are dealing with the same thing they are. They know they're not alone. They're not the only one. They have somebody that they can talk to who knows where every bathroom is and who have these tips that might help them. So get your patients connected to support groups. And again, cancer screening, essential ulcerative colitis patients, they recommend beginning routine surveillance 7 to 8 years after diagnosis, recognizing that sometimes there is a delay in diagnosis. Okay, colonoscopy, random biopsies. Crohn's disease patients also at higher risk, not as much as ulcerative colitis patients, but bottom line, any patient with inflammatory bowel disease should be getting routine colonoscopies to screen for cancer. Okay, we're going to stop there. Our next session will be on management of the patient with an ileostomy. Thanks.